My name is Dr. Joan Reed. I'm Dean for Diversity and Community Partnership and Professor of Medicine at Harvard Medical School, and thank you for joining us. There are many who have joined as registrants for today's webinar, Kidney Health. Physicians, nurses, faculty, students, trainees, administrators from across multiple schools and organizations. This webinar is sponsored by the Harvard Medical School Office for Diversity, Inclusion, and Community Partnership. The mission of DICP is to advance diversity and inclusion in health, biomedical, behavioral, and STEM fields in ways that build individual and institutional capacity to achieve excellence, foster innovation, and ensure equity in health locally, nationally, and globally. DICP efforts support the career development of junior faculty, trainees and students, and identify and train leaders in academic medicine and health policy, and also provide programs that address crucial pipeline issues. Today's webinar, Kidney Health, is offered through our DICP Equity and Social Justice Initiative. It is the first ESJ webinar as we move into this new academic year. In the fall of 2016, a planning committee comprised of faculty, staff, and students representing individuals from across the HMS community established an equity and social justice series to address health disparities, social determinants of health, leadership, health policy, and other areas affecting vulnerable populations. And since 2016, an average of 10 to 12 programs have been provided annually in collaboration with other HMS-affiliated institutions. ESJ events focus on 4 areas. 1, history and context. 2, culture and environment. 3, health disparities. And 4th, leadership and skill development. This year's series tackles health issues that often impact disadvantaged and underserved patients. Our conversations and speakers will address not just defining the disparity, but will also discuss interventions at the community, hospital, and policy levels to address these inequities. And now it's my pleasure to introduce Dr. Alden Landry, who is an emergency medicine physician at Beth Deaconess Medical Center and is the founder of Motivating Pathways, Inc. He is assistant professor of emergency medicine at Harvard Medical School and assistant dean in the Office of Diversity, Inclusion, and Community Partnership at Harvard Medical School. Dr. Landry?
Thank you, Dr. Reed, for the introduction, and thank you to everyone joining us today for this discussion. I will be moderating our discussion on kidney health as part of our Equity and Social Justice lecture series. And as Dr. Reed mentioned, this is our kickoff for the 2020-2021 academic year. We are excited to host these programs. Obviously, today we're going to focus on equity issues related to the use of race in nephrology. We're going to talk about disparities in access to dialysis for vulnerable populations, and we're going to explore some equity issues related to kidney transplantation. The reason why this topic is important is because for the past 5 or 6 months, we've really focused in on addressing issues related to COVID and the disparities associated with COVID-19 and the pandemic that's attacked our country. But the reality is these underlying health conditions such as kidney disease, cardiovascular disease, diabetes, and other chronic medical conditions haven't gone away. And in fact, many of our communities are suffering at higher and greater rates because we've been so focused in one space and we've lost track and haven't had our discussion in these other spaces. And so I'm excited to host this discussion, and more importantly, I want to just recognize the privilege it is to be joined by these wonderful panelists. We were commenting beforehand about the relationships that we all share in the networks and how much they overlap. And the panelists are either friends or friends adjacent to joining us. And it's just an honor to be here to work with them. Just a little bit of background just to organize what Dr. Reed just said. The chat is off. If you have questions, please enter those into the Q&A part of Zoom, and I'll try and get to those questions during the open question session towards the end of this discussion. But first, I want to introduce our panelists. I'll go through a series of questions with them, and then we'll open it up to questions from the audience. So next slide, please. So our first panelist is going to be Dr. Amaka Inaya. She's an assistant professor of medicine and epidemiology. She's the director of health equity and anti-racism and community engagement in the nephrology division at the University of Pennsylvania. Next slide. Next, I will introduce Dr. Ray Bignall. He is an assistant professor of pediatrics at The Ohio State University College of Medicine, and he's the director of kidney health advocacy and community engagement for the Division of Nephrology, Hypertension at Nationwide Children's Hospital. Next. Next will be Dr. Lilia Cervantes. She's an associate professor in the Department of Medicine and the Office of Research at Denver Health in Denver, Colorado, in the Division of General Internal Medicine and Hospital Medicine. Next and last is Dr. Denise Simpson. She's an assistant professor of surgery at the Division of Organ Transplantation, Feinberg School of Medicine at Northwestern University, and she's the founding director of the Northwestern Medicine African American Transplant Access Program. So just going to open the discussion right away with you, Amaka. That's been a hot topic. I've seen a number of tweets, a number of interventions happening at hospitals. There's been a large conversation about the use of race in the calculation of GFR and how that's impacted Black patients over the years. Can you just give us the basics of what is the eGFR and why do we use race as part of the calculation in this important number?
Thank you, Alden, for that introduction and the invitation to speak today. So I'm glad that you honed in on basic because nephrologists like to get really nerdy into the details, but essentially the way that the kidney filters your blood and filters toxins is very complicated. And they do this on a per minute basis all day, every day. And so some scientific investigators in the late 90s did a study in which they wanted to develop an equation to quantify this very complicated process and quantify kidney function so that you could make quick decisions at the bedside. So for instance, for specifying dosing of medications, making referrals for patients, et cetera. And so the issue with the studies, or I guess the controversial piece that's being discussed now is that in that study, when they actually measured kidney function among the participants, Black, white, et cetera, they found that Black participants had higher serum creatinine levels. So the key kind of biomarker that's used to determine kidney function was higher on average among Black patients compared to non-Black patients. And so to make this equation that they were developing very accurate, they put a race coefficient for if you're Black versus non-Black, because they felt that that would most quantify your kidney function most accurately. And that's where we are today. All of the equations that we use, eGFR equations, have this race coefficient for if you are a Black person versus a non-Black person.
It's interesting that one study sort of snowballed and led this into where we're at now. Based on the literature, why is eGFR so controversial? And shouldn't we just get rid of it, and given all the concerns that have been raised?
That's a great question. I think the core of the debate is that we've known since the Human Genome Project in 2003 that there are no biological differences between race. So outside of superficial characteristics like hair and eye color, et cetera, there are actually no biological differences. And so using race, which is a sociological construct, in a biological equation is the core of the debate. It just doesn't make sense. And the tension is that there were definitely differences that were seen in the original equation studies. The thing is, we just don't know what caused those differences. So instead of assuming that Black bodies are inherently different than other racial groups, the studies have not assessed things that we know for a fact can affect creatinine levels. So for instance, diet, high protein diet can affect creatinine levels, your physical physique, if you're very muscular, or very frail, those things can affect affect your creatinine levels. And then there's ancestry. And so rather than actually tease out the things that we know for a fact can cause issues with or can cause differences in creatinine levels, they just kind of stamped it with, well, this is what we saw in the studies with Black participants. It's the most accurate equation that we have. And so the opponents of removing race from the equation say that if we remove this coefficient, then we're not going to have really accurate kidney function among Black participants. The pushback against that is that first of all, the EGFR equation is an estimate. I just want to make that clear. It's an estimate of kidney function. There's error around that equation, up to 30% error. So it's not a hard and fast sell that this is exactly what your kidney function is. And so the pushback against the people who do not want to remove race is that we don't operate on one numerical value in medical and clinical practice. We look at the whole entire patient. We have shared decision-making discussions. We look at trends over time. And so removing the coefficient from an inaccurate equation in the first place really won't make that much of a difference when we're thinking about how it affects Black patients or Black individuals in the United States overall. So we know that there's disparities in care, and I know we'll talk about that today. And Black patients typically do not have access to certain specialists, do not have access to kidney transplant evaluations. And using this race coefficient can cause a delay in Black participants receiving care, because our guidelines use EGFR to really dictate when someone should see a specialist, a nephrology specialist, general, or transplant. And so that's the controversy. You have one group of people saying this is, marginalizing a group of patients that are already marginalized. And on the other side, you have scientists that are saying like, whoa, we don't want something that's less accurate. That's going to be harmful for patients.
It's interesting that you say this, and just trying to think about the other spaces where medicine, either currently or historically, has used race. And we know there's something similar that has happened in the past with pulmonary function testing. So we're just thinking about the many organ systems that we try and racialize in medicine. You started to get into this with your last comment about referrals and changes in care, but the downstream consequences of kidney health, whether it be issues related to hypertension, diabetes, or maybe even the use of GFR are widespread. In particular, Black patients are disproportionately affected and need dialysis. And can you dive into that a little bit more and talk about why our Black patients are disproportionately affected with end-stage renal disease requiring dialysis?
Sure. So what we know is that there's multiple reasons for this. In particular, a lot of them fall within the social determinants of health, the conditions that people work, live, and grow that we know affect health. That's how the World Health Organization defines these. So food insecurity, access to healthcare, neighborhood segregation, all of these things have been shown to affect our health. And in particular, racial and minority, racial, and ethnic individuals in this country are disproportionately affected by the social determinants of health. And so Black patients in particular are disproportionately affected with advanced stages of chronic kidney disease. And so you don't really see that racial difference in early stages of kidney disease, but Black participants progress more quickly to needing dialysis or transplant because, one, they have a disproportionate or higher burden of diabetes and hypertension, which are the number 1 and 2 causes of kidney disease in the United States. There's less access to nephrology care, or they present to nephrology care later on in the disease course. There's less access to transplant evaluations. I know Danae and others will speak about that. And then there's also the ancestry portion. And we know that there's this gene allele called APOL1 that we know if you have 2 high-risk alleles that you are more likely to progress to ESRD despite even control of traditional risk factors. And 13% of Black individuals in the United States are affected by this allele, the high-risk allele. What's tricky is that not everybody who has this allele actually progresses to dialysis. It's relatively new in the scientific literature, and we're still trying to understand that specific risk factor and how to manage that. And so it's twofold. It's socioeconomic factors that contribute to disparities as well as genetic factors.
Thank you. And I'm sure we'll get into this a little bit later, talking about race versus genetics versus ancestry, because sometimes we use these terms interchangeably when they're not. But I do have one other question that I want to get to, and I think it's something that is sort of come into prominence for me in some of the discussions and working groups that I'm in. A lot of states, a lot of hospitals are looking at crisis standards of care, and they use the SOFA score, or the Sequential Organ Failure Assessment score, as part of determining crisis standards of care and potentially resource allocation for sick patients, especially during COVID. One of the parts of the SOFA score is that it takes into account renal failure. And I know that this is a controversial issue, and you've presented some a little bit about the equity issues related to kidney health. But do you have any thoughts on this from a nephrologist perspective?
I do. I'm actually part of a research collaboration that's looking at those risk calculators, the risk calculators that are used in crisis standards, so specifically the SOFA score, as well as an author on a perspective piece that talks about the ethics of crisis standards and how this impacts minority populations. I think, the issue with the current SOFA score is that it's being used in a way that's not designed to accommodate scarce resources. That's not why it was developed. So that's one. The second thing is that patients who have pre-existing conditions, such as, for instance, kidney disease, would have a higher creatinine. So creatinine is one of the variables in that risk calculator. And the higher the creatinine, the higher your score and the less likely that you will receive, for instance, ventilator care or any other scarce resources in this course of the pandemic. And so we know that already, that I've already discussed that, for instance, Black Americans have disproportionately high or disproportionately affected by advanced kidney disease. So already they're at a disadvantage. And then also, we shouldn't, and I think this is a perfect time in medicine to really think about risk calculators or equations that determine biological function, that have variables that perform differently across groups, especially across racial groups. If there's a biomarker such as creatinine that performs differently between, on average, Blacks and whites, or older and younger, or more muscular and frail, it's not a good biomarker. And so we need to stop prioritizing these tools and these equations, because they will disproportionately affect certain groups if those biomarkers are performing differently across those groups. And so we're trying to move away from having a biomarker that doesn't perform well and then using some type of adjustment. So for the SOFA calculator, for instance, people have approached me and say like, okay, so the creatinine's in there and we know that it performs differently on average between Black and whites. And so shouldn't we have a racial adjustment? I'm like, no. We don't want to do any more racial adjustments, okay? That's terrible, especially in the setting of scarce resources. There's already so much bias that's introduced when we're thinking about race, that you're then going to introduce implicit bias into such a critical decision point. So we need to be moving away, again, from those risk tools and those screening tools that have biomarkers that perform differently. They are not good biomarkers. So that's a charge to the scientific community, that if you have a tool, and rather than the New England Journal or JAMA or some other big journal to publish it, really hone in on this is not a good tool, and really discuss that limitation, and we shouldn't use it in clinical care.
Thank you. And I think maybe to summarize it is, we need to build a better widget, because what we're doing right now isn't necessarily going to be fair and equitable to our patients. And obviously we need to do more investigating. It's crunch time. We're expecting the unexpected when it comes to what happens this fall and winter with COVID and flu season. But, we have to be cognizant of what we may be introducing as far as bias into outcomes for vulnerable populations. So I want to switch to you, Ray, and have a conversation from your perspective. You're a pediatric nephrologist, so you're coming at this potentially from a different vantage point. Amaka painted a picture of disparities in care when it comes to adults. Do those same issues exist in pediatric populations?
Yeah, so I really appreciate, first and foremost, Alden, the opportunity to come and talk to this group, this esteemed panel as well. I think this conversation is particularly germane to the work that we do as pediatricians, and in particular, pediatric nephrologists. You know, I tell people all the time, young people who tell me they want to go into pediatric subspecialty care, I say, look, if you care deeply about caring for children who are impacted adversely by social determinants of health, and you want to work on narrowing gaps in care, there's no better field to pursue than pediatric nephrology. I think first we got to understand how kids with kidney disease are different from adults with kidney disease. Indeed, children are not just little adults. They have their own challenges, and disease presents differently in them. So first and foremost, of the 40 million Americans estimated who have kidney disease, there are probably under 10,000 children that we've been able to identify with kidney disease themselves. And of that number, there's about 1,300 across the country with end-stage kidney disease, those needing dialysis or a transplant. Of the children who need dialysis or a transplant, the reason that they'll have end-stage kidney disease is radically different as well. Whereas in adults, we see a disproportionate number of individuals having end-stage kidney disease from diabetes and high blood pressure. In children, it is most commonly a result of what we call congenital anomalies of the kidney and urinary tract, CACUT for short. And then there's right behind that are a significant proportion of children with glomerular diseases. Think about nephrotic syndrome, lupus nephritis, and other conditions, nephritides like those. So the reason that kids need a kidney transplant, are placed on dialysis and need a kidney transplant are very, very different. And then when you start to look at those reasons, I think it's important to realize that despite the fact that the vast majority of these kids are cared for in academic health centers, where we pride ourselves on our progressive approach to care and our egalitarian approach to care, we still see disparities that mirror those of adult populations with kidney disease almost identically. So for example, children are referred for kidney transplant at a slower rate. Black children, that is, are referred for kidney transplant at a slower rate than white children. We know this, it's been empirically proven. We know, for instance, that the time between kidney failure and dialysis is 38% shorter for Black children, but they wait on dialysis 54% longer. So that means that their exposure to the dialysis morbidity, cardiovascular disease, neurodevelopmental consequences of being on dialysis as a therapy, it's longer for Black children than it is for everyone else. Once you get a kidney transplant, you're not out of the woods. African-American children are 1.5 times more likely to experience graft failure or loss. And even if you control for all the other covariates that we love to say are proxies for race, like socioeconomic status or insurance status, we still see that Black children lose their kidney transplants more often, rather sooner, than non-Black children. In fact, this disparity grows dramatically after 5 years of a child having a transplant. So there are a number of disparities that we see in pediatric kidney disease that mirror those of adults with kidney disease, and we need to figure out what we need to do to address those.
Interesting. You know, as you were speaking, I was thinking about bias in pediatrics, and I was thinking about other issues like social determinants of health and genetics. Can you talk about the impact of the social determinants of health on kidney disease in pediatric populations? And how does that compare to maybe genetic issues? And then maybe talk a little bit more about the bias that may exist in pediatricians and pediatric medicine when it comes to kidney health for the patient population?
Yeah, absolutely. So this is, I think, really key to understanding what it is that drives disparities among Black and brown children with kidney disease. Quite honestly, kidney disease in children is a disease of social disadvantage. We see outcomes that are dramatically different for children who are disadvantaged regardless of their racial background, but especially among Black and brown children. It has a lot to do with many social determinants of health. So for instance, when you have kidney disease, there are certain diets that you might need to adhere to in order to avoid the dangerous sequelae of your kidney disease. Things like a low phosphorus or low potassium diet might be a lot harder for many children who grow up in food insecure communities to be able to adhere to than those who are not in a food insecure neighborhood. And as my colleague, Dr. Amaka, she referred to earlier, we know that those kids are disproportionately those in Black and brown neighborhoods, many of them in inner cities across the United States, where because of the legacy of redlining and residential segregation, we see this dramatic disparity with regards to food access. So that's one area in particular. Risk factors that have to do with housing stability. If you are a child who needs peritoneal dialysis, this is the ideal form of dialysis for children because it affords them the ability to disconnect from their dialytic modality and be able to go to school, or for our older adolescents, go to college or work. When it comes to peritoneal dialysis, regulations state that a person's home has to be structured in a manner where they can connect the child to the dialysis machine safely for their dialysis session. Often that requires that the child dialyze in a room with a door that closes. Well, if you live in a poor family and say you're in an apartment building in some large metropolitan area, a one-bedroom home with you, your mother, your father, and perhaps several siblings, you might find that you're not the one in the bedroom. Most likely very challenging to allocate that resource to within a family like that. So there are a variety of challenges where social determinants of health come into play. Say nothing of the impact of systemic racism on how these children procure care and what happens to them after they're in care. Implicit bias threatens so many of the structures in pediatric nephrology. I know Dr. Simpson is going to talk about later, I'm sure, some of the bias that's involved in allocating scarce resources like organs and how that impacts children, especially children of color. And I know from personal experience, having done some work in adherence as a postdoc fellow during my time in training, that this is a remarkable area where you just read a few pages of medical apartheid and you'll realize how the charge of non-adherence follows Black and brown patients when it comes to the reason for their disease progressing in an adverse manner. So there are a host of barriers, social, structural, industrial, environmental barriers that hamper the success of children with especially end-stage kidney disease.
Thanks. I think there's a lot to unpack with what you said, so maybe we'll get to more of that in the later discussion with our audience. But I wanted to just transition to, you made a couple points about transplantation in pediatrics as far as the survivability of the transplanted organ and the disparities that exist. And Dr. Simpson is going to talk about this as well, more so from an adult perspective. But can you just, again, paint the landscape of the issues and equity related to renal transplant in our pediatric populations?
Yeah, so this is an area where I think there's a lot of room for folks to investigate and learn more. One of the big barriers that we have right now to kidney transplantation in the Black community in general, but especially among children, is access to transplant. quite frankly. Some of my friends and colleagues at Hopkins, doctors Purnell and Cruz and others, have published work that shows that actually of all of the racial and ethnic demographic groups in the past decade or so, African Americans are actually the only racial and ethnic demographic group that is less likely to be willing to be living donors than they were in the 10 years previous to that. Has a lot to do with this concept of iatrophobia, the idea that many Black and brown communities in the United States are quite frankly worried about the kind of care that they will receive from physicians when they arrive. And it has a centuries-long history in this country that is perpetuated through, unfortunately, modern depictions of racial injustice in healthcare. I think that understanding this dynamic is key to appreciating some of the roadblocks to successful transplantation and success of transplantation in children. I know that my colleague and friend, Dr. Cervantes, will talk about this here shortly, but I worry, quite frankly, a lot about our undocumented patients and families when it comes to transplantation. You know, this is a huge challenge that we in medicine, have to fight against, given the reticence that many of our undocumented neighbors feel about receiving care from us here in big academic centers and what that might mean for their families' status in this country. So these are also things I think that are really important to consider. You know, I had a patient come see me in clinic the other day, a Black young lady, school-age child with nephrotic syndrome that's really difficult to control. And a couple of my colleagues were working on getting her enrolled in this study, a research study that would hopefully help to illuminate some issues and aspects of her difficult to control nephrotic syndrome. This young lady had her two parents with her mom and her dad. Her dad was adamant that he did not want her to be a part of the research study. It took a lot of cajoling and understanding from my really terrific colleagues before he reluctantly agreed. When I went in the room after they had consented and I introduced myself, it was my first time meeting them, I sat down, I looked in the eye, I said, listen, I want to let you know before we even start talking about your child's care that I understand where you're coming from with your hesitancy about taking care of your daughter and what being a part of a research study might mean for that. And I'm going to give you my word as a Black man in America and as your child's physician that I won't allow anyone to do anything to her or with her research data that will put her in harm's way. This strong, proud Black father immediately broke down weeping in the room. And I understood why he was crying, because I feel like for the first time, here is a medical provider who said, I see you. I know what you're feeling about your concern for your child. I know that you know the history of what happens in this country to people who look like you and me, and I am ready to help stand with you in protection of your child. I think all of us across the medical community need to have that same approach and mindset when it comes to dealing with health disparate populations, especially children.
Yeah. Thank you for sharing that story, Ray. I think it's really important for us to think about how we unpack the other issues that may follow the patient or their families into the hospital, into the clinics, into the operating rooms, and how do we address those potentially bigger concerns that are often overlooked in medicine because we're so focused on the numbers and we're so focused on medication adherence or whatever it may be. Making sure that those patients show up for appointments, not understanding the context of which our patients actually live and interface with medicine. So thank you for sharing that story. I think it adds a lot of context to what we're talking about here today. I want to turn to you, Dr. Cervantes. Your work focuses on the Latinx community. Can you just give us a brief overview of where we're at when it comes to the disparities or inequities when it comes to our Latinx patient populations and their issues with kidney health?
Absolutely. I just want to start off by thanking you for having me on this incredible panel and for the opportunity to share some of my work. So just very briefly to sort of ground ourselves on the Latino community, they make up about 18% of the US population, and about 20% of the 60 million Latinos in the country are not citizens. They're heterogeneous with regard to race, language, health behaviors, and cultural traditions. And then next slide. Specifically with chronic kidney disease, a recent study looked at U.S. temporal trends in kidney disease and found that the prevalence of kidney disease had stabilized for non-Latino groups over the last couple of decades, but it has nearly doubled for Mexican Americans. And as was described earlier, some of the reasons for these disparities are complex and tied to the social determinants of health, some of which are modifiable. And one that I want to highlight that is modifiable is access to care. It's estimated that about 20 to 40% of the Latino community, both documented and undocumented, has no health insurance. And many of them are underinsured or have very large copays. For Latino patients, diabetes is one of the main causes of kidney failure, but it can be prevented, and its progression to kidney failure can also be slowed through the use of lifestyle changes, control of blood sugar, as well as use of medications. However, for Latinos, Latinos tend to have poor control of their diabetes and use of those medications, and they also tend to have low awareness of their kidney disease. And other factors related to inadequate care are low trust, provider bias, communication barriers, because oftentimes language interpreters are not provided, as well as cultural differences. And so we need to do something to eliminate these disparities. And one way to improve awareness of kidney disease and access to care in a way that is perhaps trusted and culture and language concordant is through the use of community health workers. Community health workers are lay individuals. They're part of the community. They tend to be employed by trusted community-based organizations, and they can connect with patients to provide kidney disease prevention education, conduct screening tests, refer to healthcare, and encourage medication adherence. Another study, Amaka mentioned this earlier, that looked at pre-dialysis nephrology care found that Blacks and Hispanics are less likely to receive pre-dialysis nephrology care. And this is important because receiving nephrology care before starting treatment for kidney failure is associated with improved survival, as well as other outcomes like quality of life and overall better preparation for dialysis or likelihood to receive kidney transplant. The 2018 USRDS report showed that peritoneal dialysis and preemptive kidney transplants were less common among Blacks and Latino patients, and they're also more likely to start hemodialysis with a catheter. And so in that setting, you can imagine a community health worker also working with patients as they navigate the transition from kidney disease to end-stage kidney disease, you know, as far as support with decision-making in a way that's culture and language concordant. Lack of access to care is even more pronounced in undocumented immigrants because they're excluded from public benefits such as Medicare, most Medicaid programs, and the provisions of the Affordable Care Act. And so their access to preventive diabetes, kidney disease care, and regular care for kidney failure is devastating.
Thank you. And you mentioned that the Latinx community is very heterogeneous and not homogeneous. And I think that's something we need to stress in these discussions when we talk about these large groups and the way we group racial categories. And it's not just that you know, if you're Latino, that you are from Mexico or you're from Central America. There's a lot of differences in between those groups. There's differences in the amount of time that they've been in the U.S., whether they're first generation or fifth generation, or whether they're an undocumented immigrant, or whether Spanish is their primary language for communication when it comes to health, or whether it's English. And I think that we often make these groups and then assumptions which lead to the bias and the disparities in the care that our patients receive. But I wanted to touch on a little bit more of what you were saying about undocumented communities. You mentioned that undocumented immigrant communities with kidney failure have limited access to resources, and that's where your work is focused on. Can you talk a little bit more about the work that you're doing about caring for undocumented individuals in our country?
Absolutely. Next slide, please. There we go. In Colorado, we had, so prior to 2019, we had about 120, 130 undocumented immigrants with kidney failure. And back then, undocumented immigrants had to come to our hospital about every 6 to 7 days to receive emergency dialysis. And so as a hospitalist, we were admitting these patients once a week. So they came in basically at the brink of death because they had to meet objective criteria to receive emergency dialysis. And it was devastating to see these patients week by week. And a patient that I connected with is the woman you see pictured here, Hilda, with her 2 boys. She was undocumented, diagnosed with kidney failure, came in on a weekly basis. And after about a couple of years, she had suffered several cardiac arrests and knew that her days were numbered and didn't want her boys to end up in the U.S. foster system. And so she ultimately decided to stop emergency dialysis. And prior to doing so, we worked with her closely to find an adoptive family for her boys. But after she passed away in Mother's Day in 2014, I decided to focus all of my work, research, everything on changing access to care in the state of Colorado. And so nationally, there are about 6,000 to 9,000 undocumented immigrants in the country. They tend to be Latino, male, employed. And for the most part, many of them have lived in the country for at least 5 years before they were diagnosed with kidney failure. And as many of you know, because of the Medicare end-stage renal disease entitlement program, U.S. citizens can receive kidney replacement therapy, but undocumented immigrants do not have access to those benefits. And their care kind of varies throughout the country because for these patients, reimbursement in many states tends to come through emergency Medicaid, meaning they have to meet critical illness to be emergently dialyzed. And next slide. And so in my journey to try to change this, I engaged several different types of stakeholders, conducting research along the way and demonstrating worse outcomes faced by the undocumented community. I started by connecting with patients. I connected with 20 patients one-on-one to try to better understand their experiences receiving emergency dialysis. And I found that many of them experience significant physical and psychosocial distress because, as I mentioned, they have to wait 6 to 7 days for all of their symptoms to accumulate just so they can receive dialysis. One of the things that was happening is that we were seeing an increase in the number, and so the dialysis chairs, we often didn't have enough dialysis chairs for these patients and had to base admission on potassium. And so many of these patients would consume something high in potassium just so they could be dialyzed, knowing that they could arrest in our emergency department. I also connected with caregivers. Many of the caregivers had children of their own, and so they described the psychosocial distress that their children faced. In fact, 2 families described suicide attempts in their kids because of the fear of losing their loved one. And many of them also described how their kids had to drop out of school or miss school, and so were graduating later because they were coming with their loved one to the hospital to try to provide language interpretation and support. And then finally, I connected with interdisciplinary clinicians as well, both in Colorado and at Harris Health, and learned that my experience was not unique to me and that a lot of people were suffering burnout because of this. Many of them described the drivers of burnout being sort of from witnessing the needless suffering and high mortality, because we were seeing these patients look great after their 2 sessions of dialysis and then come back 6 to 7 days near death. Many of them felt like they were jeopardizing their patient's trust because when we had to discharge them from the ED because their potassium wasn't high enough and they were visibly ill, it just didn't feel right. I also connected with other types of stakeholders to try to understand where there are gaps in the literature and where research questions could sort of inform opponents. And we conducted some quantitative research as well. One was a retrospective cohort analysis looking at mortality differences. And we found that undocumented immigrants have a mortality that is 14-fold worse 5 years after starting dialysis compared to undocumented immigrants that receive standard dialysis. Healthcare utilization is also 10-fold worse. I looked at the characteristics of patients that had passed away soon after presenting for emergency dialysis and found that many of those patients had a very high potassium with a mean of about 6.2 and, a diagnosis at time of death of cardiac arrhythmia or arrest. And so I began this journey back in 2014 after Hilda passed away, and after about 4 to 5 years of stakeholder engagement, research, and advocacy, Colorado Medicaid decided to include the diagnosis of end-stage kidney disease as a qualifying condition for emergency Medicaid. And so very exciting that as of February 1st, 2019, undocumented immigrants in our state now have access to standard dialysis. And this is something that has taken, that has been picked up across the country. And so it's very exciting that now several states have followed the same course and expanded access to care for undocumented immigrants.
Wow, that's just an amazing story, and to hear about the progression of your work from a single patient interaction into expanding into all of these phases, whether it's research, advocacy, policy interventions. And I think it's really important for us to hear these stories, because sometimes all it takes is an N of one to really motivate us to make the changes that are needed to benefit not only the patients that are before us, but the ones we know that are potentially coming down that we're going to be seeing in the future. And it's just a testament to the work that you have done and your colleagues to help get access to care for such a vulnerable patient population. You know, as we talk about the changes that were done in Colorado and through your research, and can you give us a general sense of how other physicians might mitigate, might translate their research into advocacy or policy change? And how can we take your lessons, your experiences, and look at this either from the work that we're doing on kidney health or into other areas that we are passionate about? And how do we take that research to advocacy and policy?
Yeah, let's see, next slide, please. So just very briefly, sort of going to my example, I started off by gathering a coalition. As I mentioned, I engaged different stakeholders, and something that was really important were those qualitative narratives, because people were sort of able to identify with some of those narratives, and it ended up growing our coalition of people that were very interested in changing this. Those narratives also captured the attention of media, and media helped us sort of reach an even wider audience, which was incredible. And we gathered data. We gathered the qualitative interviews. We also conducted a cost analysis. So our hospital was providing care to the majority of those 120 undocumented immigrants in the state. And so we compared emergency dialysis, which ends up being, typically when you admit someone for that, it's, you know, the diagnosis ends up being like severe life-threatening hyperkalemia, and the reimbursement for that is around $6,200 to around $6,000 to $8,000. So compare that reimbursement once a week to Medicaid reimbursement for standard dialysis, which tends to be around $700. And so that internal cost analysis was really important to sort of make the case for our state Medicaid agency. And then separate from that, we also conducted a policy analysis, and we learned that state legislation was really not the right way to go, because it would highlight you know, access to care for immigrants during a time when there's a very strong anti-immigrant sentiment. And we also realized that CMS was not, CMS approval was not necessary, because CMS and the Office of the Inspector General defers to states to make decisions around each state's individual Medicaid, emergency Medicaid program. And so ultimately we found that the sub-regulatory language change was really all that was necessary. And we were able to sort of focus our strategic advocacy. And so next slide. And so for folks interested in advocacy, if there's something that you're passionate about, like a clinical challenge or structural inequity, and you want to create actionable change, there's a few steps. First, think about the advocacy issue that you want to work on. What is it that wakes you up in the morning and makes you angry, that you just want to fix, that you're okay spending extra time on? And then describe the problem as a policy. So sometimes, usually, people think about policy with a big P. So they think about policy as laws and regulations and things that are highly codified and complex that require a great deal of effort to change. But think about the policies in a broader sense, policies in practice, the policies that you yourself have when you get up in the morning or you see your patients. So like the established ways of doing things. And then next, to describe that change you would like to see as a policy. So what would be the change, and how would you describe it? How would you craft that message? And then identify who can change those policies. You know, are there key stakeholders, key decision makers, and begin to sort of craft your message, not just for those key decision makers and allies that you identify, but for the opponents. And, you know, that was something that was extremely helpful for me as I thought about the research questions that I wanted to ask. And I'll just end with sort of a reflection I had with one of my mentors this past week when discussing advocacy. And it's the cost of speaking out versus the cost of not speaking out. So many of us have that choice, and we can either do something or we can swallow it and move on. And I think that it is cathartic to speak out, and it's costly when we don't speak out. It can be a great moral injury. And lastly, one of my role models, Patty Gabo, she was a nephrologist here at Denver Health and then eventually the CEO of our hospital. She described courage in one of her healthcare leadership panels this past week. And she described how courage in a leader is being willing to take a position and being willing to lose it on behalf of speaking out for patient well-being, on behalf of advocating for patients. And so, you know, I think it's important to sort of be involved in the change that we want to see.
Awesome. Thank you for sharing. And I think that's a lesson for all of us. It doesn't matter where you're at in your career. You can be a medical student or a trainee, or you can be someone a little bit more seasoned in their career. But if there's something that gets you out of bed in the morning or keeps you up at night, maybe it's time to step up and think about how we can address patient advocacy from a policy level. And I think it's also important, and one of the things that I liked hearing is you had the stories to pull on people's heartstrings, but then you also talked about the dollars and the cost of this to pull on the purse strings, and you recognize the importance of those different leverage points in advancing the work that you wanted to do. So thank you for sharing. I want to turn to Dr. Simpson now and just have a discussion around kidney transplants and the issues that may be present in this space of kidney health. So we learned from Amaka how to address kidney disease and how prevalent kidney disease is in the Black community, and the impact of social determinants of health, as well as some other issues at play. Can you talk to us about the barriers that patients experience if they have to move beyond dialysis as part of their medical care to the referral to the transplant physicians for their evaluation and furthering their care?
Absolutely. And first, I want to thank you in Harvard for the opportunity to talk about this important topic with these incredible colleagues, these panelists, some whom I'm meeting for the first time, some whom I've been friends with for a while. And listening to all of you guys speak is just so inspiring every single time I hear you speak. And so it's really just a pleasure to be on a panel with you all talking about something that's so important to me. I mean, I'm just a simple surgeon, but you know, this is something that I come across in my daily work, but it's also something that I come across in my everyday life. You know, I often say that I have yet to meet a Black person who isn't affected by kidney disease in some way, shape, or form. And we talk about the 7 degrees of Kevin Bacon or whatever. I mean, it's less than 7 degrees for us, right? I mean, we either are affected by it personally, or we have a family member who's affected by it, or we have a friend. I mean, it usually doesn't go much beyond that. And so it's a sad reality that kidney disease has become so commonplace and accepted in the Black community. And yet many, many people don't recognize the barriers that are in place when it comes to seeking treatment. I mean, I think the first barrier is knowing that kidney disease affects, how profoundly it affects us, and that it's really silent in its early stages. You know, one number I like to throw out there just to kind of drop the jaw of many people, because, you know, most folks don't know this, even people in medicine. And Ray gave this statistic as well for children, but Black, you know, people represent about 13% of the US population, yet we represent 35% of all Americans with kidney disease. So you guys gotta sort of think about that for a minute. I mean, that in itself is a huge disparity, but the disparity doesn't stop there.
Once a Black person is screened and found to have kidney disease, we're less likely to be referred to a nephrologist prior to the initiation of dialysis. And so Ray talked about this, Lilia talked about this in the Hispanic community. And so it's a big problem. And when we are actually referred to a nephrologist prior to dialysis, that referral often happens at more advanced stages of kidney disease. So what this does is it sets us up to lose the benefit that many others may have by being able to plan with our nephrologist, to think about when dialysis is going to become necessary, what we might be able to do to slow the progression of disease, and what treatments beyond dialysis may be available to us, namely transplant. I often have patients tell me that they crashed onto dialysis. It's like, oh, doc, I was not feeling well for a few weeks, and then one day I woke up in the ICU and I was attached to a dialysis machine, and the rest is history. And although some of those patients may eventually come around to seek transplant, they've lost the immense benefit of preemptive or early transplant because of the lack or delay in referral. And so at this point, some people will ask me, well, does it matter when somebody gets transplanted as long as they're transplanted? And Lilia commented on this a little bit in her talk is yes, it does matter if you get transplanted early or not. When I encounter patients of any ethnicity, usually, when they meet me and they want to talk about transplant, their main objective for getting transplanted is to improve their lifestyle over the current lifestyle they have with dialysis. I rarely ever have a patient come to me and say, doc, I would like a kidney transplant to improve my survival over what it would be on dialysis. But the truth of the matter is the reason transplant is considered the treatment of choice over dialysis is that it's been demonstrated to give a survival benefit when you compare to similar groups of people who get transplanted who remain on dialysis rather. And depending on the paper and the cohort being examined in the medical literature, survival benefits of transplant over dialysis have been demonstrated with a mortality reduction up to 70%. So it's a significant improvement. And while this is substantial, there are even greater benefits to be gained by never seeing a day of dialysis and the risks that dialysis bring. So preemptive kidney transplant is associated with improved patient and graft survival, as Lilia said. But because of the disparities that I mentioned earlier, Black patients are less likely to have access to those benefits because of significant delay in referral. So that's some of the barriers that patients will experience in getting to see me or someone like me, when as a transplant surgeon. Here in Chicago, geography plays a role, and I suspect that that's the case in many other locations. As many people know, Chicago is a very segregated city. And not surprisingly, if you were to look at some maps, I love to show maps when I have this conversation with folks, and you can see the different areas of Chicago where our Black and brown communities are clustered. And in those same areas, those neighborhoods are overrun with dialysis centers. But most do not have access to specialty care that are similar affluent white neighborhoods would have. And in this case, that's nephrologists. Additional maps I like to show the social determinants and their impact on kidney health and access to a transplant in Chicago. And in this case, living in a specialty desert is a social determinant that is very impactful on residents in these neighborhoods and their ability to access specialty care and transplant referral. Additional maps that I show, some of the conversation earlier talked about food insecurity, in how that plays a role in sort of the transplant progression, leading to obesity, leading to diabetes and hypertension, which are the top two causes of kidney disease. And so then you start to see how these, social determinants start to build, the system has become designed to fail our communities from the very beginning, before they even come to see a transplant center. And I'm sure Chicago is not unique in this. So there are many barriers that patients will hit before they ever get to see a transplant center.
Thank you for sharing. And I think it's really important to think about, I know Ray mentioned this, and I think Amaka as well. There's historical context to this with redlining and how our country is approached, who gets to live where, and then you overlay that with all of the disparities that exist, whether it's where the hospitals are located versus where the food deserts are, or the other issues, or where the over-policing may be occurring, and how that's typically where our vulnerable and our marginalized patient populations are living. So I think there's a lot to unpack there. I think it's also interesting as you talk about the distribution of resources in the form of providers, and how we may have community health centers, which do amazing work in care for our patients, but the lack of access to to the specialty care. I know here in Boston, we have similar situations. We have such huge number of pediatric gastroenterologists compared to the rest of the country, but are they serving all of our patients equally? And, we talk about this in mental health as well, how urban areas are overpopulated with mental health specialists, but not necessarily in our rural communities. So how we distribute resources in the form of healthcare providers is something that we also need to look at, which is another huge topic of discussion, which we don't have time to dive into today. But I do want to get back to what you were talking about a little bit more about the transplant process and the challenges that our patients of color may be facing. Do you want to just dive into that a little bit more about what our patients of color may be experiencing when they are, it's deemed that they need a transplant, or should be deemed that they need a transplant?
Sure. This is one area where the literature does not fall short. If there is one thing that Black and brown patients, kidney patients, are not lacking, it's documentation of all the barriers that we face when navigating the transplant process. The literature has been documenting these disparities since the 1980s, the early 1980s, yet here we are, 2020, and there have been very few interventions designed to address these barriers. The transplant process, I think, is unlike most other aspects of medicine. The treatment is very limited in supply, and being in need doesn't guarantee that you're gonna get treatment. Even if you have everything else in place, you have, the right insurance, you have the right education, you have all the barriers have been done away with, you're still not guaranteed to get that treatment. So it's very different than other aspects of medicine. And, geography also plays a role. The local hospital for many patients don't offer transplant. So there becomes, an additional barrier of having to travel. Allocation for transplant is in the hands of a group of people who are charged with the task of objectively evaluating each patient to determine their suitability to receive and care for their organ. This is the Transplant Committee, and the Transplant Committee was designed with equity in mind, yet there are many areas where structural, institutional, interpersonal racism can come into play and adversely affect an individual's chances of making it through the multi-step process that is evaluation before being listed. The way I like to think about transplant, I'm often, very visually minded, and I like to draw a picture of concentric circles. The first biggest circle is, the first step, and then you kind of pare down as you eventually get to that point where you get transplanted. And the reason why I do it as concentric circles is because as you move through each step, you're gonna lose some people. Not everybody who needs a transplant or who has kidney disease, let's put it at that, not everybody who has kidney disease is gonna make it down to that final small circle and be transplanted. And part of that is intentional. There are several patients who aren't suitable candidates for transplant for objective reasons, such as they have stable disease at the time and transplant's just not where they should be at this point in time. Or maybe for comorbidities that would preclude transplant, such as a coexisting cancer or having vascular disease. Transplant is very much vascular surgery. I always tell patients that putting in a kidney is like putting in a sink. You have to connect pipes that bring water into the sink. You have to connect pipes that drain the sink. And those are our blood vessels. And if somebody has vascular disease, you just can't do a transplant. Other reasons that would prevent somebody from having a transplant are psychosocial issues, which is a very broad category, but that can include some very, objective things such as insurance, and that can be, more of the yes or no answer. But there are other areas of the process that are less objective, and they're subject to bias, and these create the barriers that have been well documented in the literature. And so one example is communication. There are several papers in the medical literature that demonstrate that Black patients or Black patients in focus groups will tell researchers that they have poor communication, they experience worse communication than their white counterparts will report. And this leads to misunderstandings. And so, for example, there's a study out of Baltimore looking at predominantly Black dialysis centers, and 51% of the patients who participated in this study reported that they were listed for transplant, but in reality only 31% were listed. So there's a miscommunication here. There's something not right when when these patients are trying to navigate this transplant process. And miscommunications such as these will strain the relationship with the transplant center. And so that adds to distrust on the patient side, which is a huge barrier for patients. They're already, coming to us with a lot of distrust in the healthcare system, as we've previously mentioned in this webinar. And then provider bias will also be worsened, if patients are coming with miscommunications. Oftentimes these miscommunications lead to patients failing to do certain tasks, like specifically like, oh gosh, I don't need to do this anymore because I'm listed. No, actually you're not. But then that's misinterpreted as a patient lacking interest in the transplant process, or being non-adherent, or not completing what they're supposed to, what was laid out for them to do. Another broad area is health literacy. And so the literature shows us that patients of low socioeconomic status and non-white ethnicity are much more likely to have limited health literacy, which will directly impact their ability to make it through the transplant process, which is very complex and often times requires the patient to be very self-directed as they're navigating this process. A lot of patients don't have personal navigators. A lot of transplant centers don't have personal navigators who can handhold and walk these patients through the process. And while there are, just a ton of other barriers to discuss, the last broad area I would like to highlight, it falls under the psychosocial category. So this is where we categorize areas such as social supports, compliance, or non-adherence. This is a very gray area. It's a very soft area, and it's very, very open to bias. And I think the best way to example how these can present barriers to patients is through example. So let's take compliance for example, or non-adherence is adherence versus non-adherence, as some people like to call it. And compliance with medication, so immunosuppressive medication specifically, is incredibly important because non-adherence will lead to rejection and graft loss eventually. Transplant is subject to quality standards that other surgical programs are not. We are audited on a regular basis, and poor graft outcomes can lead to flagging of a transplant center, or even putting a center on probation or closing it down. So this will certainly incentivize providers to think about compliance beyond just looking out for the patient. Obviously, we're very interested in our patients doing well, but we're also going to be interested in the outcomes of our transplant program, which is our livelihood. So take, for example, a patient who's been denied listing due to perceived non-compliance. Because if we detect as a transplant center that this patient's not going to be compliant, we can kind of look down the road and think, okay, if they're not going to be compliant, they're going to have rejection, they're going to lose their organ. Most importantly, this is an organ that could have helped someone else. So obviously that's the number one reason for looking at compliance. But also, as I said, we got to think about our transplant center. If our transplant center is shut down, there are countless other people we can't serve, right? So these are things we have to think about. We will often, we have to figure out how to gauge compliance for a patient. So oftentimes a transplant center will turn to dialysis records, which can be a proxy for compliance. Non-compliance can be interpreted from repeated misses of scheduled dialysis sessions. or the need for emergency dialysis in between sessions, which may be from dietary indiscretion, from salt or potassium or volume overload. Another way to kind of interpret dialysis records is a person who decides to terminate their dialysis sessions early. And these are all examples that I've come across, in my day-to-day. And so these present as red flags to the transplant committee. And once a committee grabs hold of these, it can be very challenging for them to change their perception of a patient. But there may be reasonable explanations for these red flags, but unfortunately bias will start to get in the way. And so, example, I mentioned missing dialysis sessions. I've had a patient who missed dialysis sessions repeatedly because she had limited childcare resources. She was a single mom caring for her children. And so she would miss a session here and there. Now, what the dialysis records didn't really show very well is that she would reschedule that session on an off day. So if she was Monday, Wednesday, Friday, she missed on Monday because her son was sick, she would reschedule on Tuesday. But the damage was done. So can you imagine how this could go poorly then? The transplant coordinator confronts the patient with noncompliance. Miss, you've been noncompliant. The patient gets defensive. And so therefore, in addition to being labeled by the committee as noncompliant, she's also received the label of being difficult, of being angry. And, I've seen things like this happen far too many times, and the literature supports it. Psychosocial is a major barrier to patients, and it's just such a gray and an area that's just full of opportunities for bias.
Wonderful. And I think that it's really important for us to think about all the bias that we bring into medicine. Sometimes it's structural, sometimes it's interpersonal, and it's really important for us to think about what we're bringing to the table as an individual, what our system is bringing into it. I recognize the importance of centers remaining certified, but do we do that on the backs of patients who really need our care? I have one more question for you that I want to jump into, and it's it has a long answer, but I would ask you to try and be short in your response because I see questions popping up from the audience. And for the audience members, we're going to try and get through some of your questions. So if you have a question, please put those in the Q&A portion of the Zoom. But again, long, tough question, and hopefully you can do your best to give us a short but impactful answer. How can we better engage communities of color to become organ donors?
Yeah, I mean, it is a big question, and it's something that I'm kind of on the periphery of, but also, it affects me and my work very profoundly. Communities of color have been shown for, since the beginning of organ donation to be less likely to be organ donors, and a lot of this is rooted in distrust, also in myths and misperceptions around transplant, around organ donation. I think when you think about, when you want to answer that question about how we better engage communities of color to become organ donors, the absolute best example of this is to learn from Dr. Clive Callender in the MOTEP program, in my opinion. MOTEP stands for Minority Organ Tissue Transplant Education Program. For those of you who don't know, Dr. Callender is one of the first African-American transplant surgeons in this country, and he is still very active in raising awareness around organ donation. And so he made enormous strides, basically by engaging the community. Since the inception of the program in 1978, he has more than quadrupled the number of minority organ donors per million. So he's made an enormous impact, and we should be following his example. And so to keep it short, what he really did is he went into the community and learned from the community what their barriers were, rather than showing up in the community and saying, hey, these are your barriers and this is what we're gonna do about it. So learning from the community, I think, is really the most important piece of what he's done. After he engaged with the community, he was able to kind of boil it down to 5 major areas of intervention. And so from his paper, the 5 areas are lack of transplantation awareness. So education is key. religious beliefs and misperceptions. You know, our country has a lot of dark history when it comes to, you know, just medicine in general. And so distrust, myth, and misperceptions will grow from that and further worsen disparities. And then you also have lack of cultural understanding on the part of medical providers and understanding how things like religion interplay with their day-to-day decision-making, particularly when it comes to healthcare. Distrust of the medical community, as I mentioned, fear of premature declaration of death after signing a donor card. This is probably the #1 myth, misperception in communities of color when it comes to designating as an organ donor. They fear that someone will take a look at their driver's license when they roll into the emergency department, see that they're an organ donor, and stop all efforts to save their lives. So again, education is going to be key here. And then the last thing he discovered was fear of racism, in the sense that organ donors were afraid that if they were an organ donor, that their organs would not be added to a general pool that would hopefully help members of their community. And they were afraid that their organs would go preferentially to white people and people of influence and privilege. And so through working through all of, you know, through these 5 major areas, he's been able to make a major impact. So the short answer is engaging with the community, learning what they perceive their barriers to be, and then creating your intervention based on that.
Wonderful, thank you. I saw a lot of head nodding from the other panelists, so I think we're all in agreement with what you just said, Dr. Simpson. I want to turn to audience questions and try and get through a handful of these given the short amount of time that we have remaining. But just again, thank you to all 4 of you for your wonderful presentations. Amaka, I want to turn to you with this first question. There was a discussion and you mentioned race and ancestry. Can you dive into this a little bit more? And can you just talk about, hopefully quickly, again, given how broad the question is, about the general issue in using race versus ancestry in a lot of this work that we're doing in medicine?
Yeah, that's a great question. And I think it's a misconception in the medical community now in terms of, especially race being on the forefront of many public discussions, that we can just replace race with ancestry. And that is extremely false. So there was a large study that came out in July that looked at the genetic and ancestry of the African slaves that were stolen from Africa to come here. And they found, it was published in the New York Times and the American Journal of Human Genetics, and they found that what we thought about ancestry was false based on 23andMe results, and that there was much more contribution from women, African women, much more contribution from European men, which speaks to sexual violence and all of the other things that terrible things that came with slavery. And so, you know, there have been some studies that show that self-reported race correlates with ancestry, but that's broad continental ancestry. And I'm sure we all know of one person or several that have gotten their 23andMe results and been like, oh my gosh, I'm like 50% European. So I think you can probably relatively guess what continent has contributed to your ancestry. But when it comes to disease risk, we really need to know more about individual genetic risk. So for instance, I have the privilege of being tested for APOL1. I'm a first generation Nigerian American, so I know exactly what my risk is and what the risk for some of my family members. And so, you know, when we're thinking about race and EGFR, should we treat someone like me, a first generation Nigerian American, or my family member who may just be an immigrant, the same as someone who has been here for several generations based on ancestry? And so I think we really need to be, you know, to distinguish between continental ancestry and individual ancestry, which would basically mean genotyping the entire population if we really want to know specific risks. But that's where we need to move towards as a field to really achieve precision medicine. And we shouldn't think that we can replace race with continental and broad ancestry. That's just false and not scientifically sound.
Yeah, and it's an interesting discussion because when we talk about precision medicine, making sure that the interventions that we're developing from a genetics perspective are things that are equitable and fair to all patient populations and don't necessarily focus on a disease that may be more prevalent in a dominant race, for lack of a better term. And that's where we tend to focus our time, efforts, and funding. Whereas costs for interventions or for genetic interventions and genetic studies for other populations may not be put so high up on the importance ranking. Ray, I want to turn to you for a question. We talk a lot about the medical community and its role in bias and towards patients. What interventions can be done? What are meaningful interventions, let me say, that can be done to help address these issues around bias that come from the providers towards our patients?
Yeah, I appreciate that question. I actually see it here in the chat, reference to a person of color, I think first-gen medical student at Northeastern University. I want to tell that person that they're part of the solution, quite honestly. I agree with this medical student's assertion that we need to look beyond the implicit bias workshop, which may be challenging for some who may have just discovered the implicit bias workshop as their hopeful panacea to addressing issues of systemic racism and discrimination in medicine. You know, I think what you've heard as a through line through all the presenters today is the importance of engagement. We need to be engaging communities. We need to be engaging institutional leaders. We do this with any medical problem that we come up against. We have basic scientists who go into the lab and they investigate the molecular origins of disease and pathology. We then translate that understanding from an in vitro circumstance to an in vivo circumstance. And then we engage the medical industry to develop devices, therapeutics, treatments to address this in a real world population. I think we must do the exact same thing when we approach issues of systemic injustice in medicine, or systemic injustice in society rather, that impact medical outcomes. So for example, we need to be engaging communities early about these challenges. If I'm a pediatric nephrologist and I know that a significant number, I'll give you an example. A great colleague of mine, Dr. Michelle Starr, who is a pediatric nephrologist at Indiana University Riley Children's Hospital. She published some really tremendous work a few years ago that showed that as many as 60% of children who receive dialysis in center are food insecure. Okay, 60%. I'm sending 2 out of every 3 children from my dialysis unit back into an environment where their poor nutrition will most certainly impact their clinical outcomes. Well, what do? We develop a food pantry, which is what she did. Developed a food pantry to help provide those children with what it was they lack. That required engagement. It required engagement of multiple stakeholders in a similar fashion as to what we would do if we developed some new therapeutic or medication. That's just one example. I think when it comes to dealing with these structures of injustice, we need to, as physicians, move outside of the ivory walls of our academic centers and begin to think creatively. Like Dr. Cervantes, you know, how are we going to start to engage policymakers? Dr. Simpson noted the importance of Dr. Collander's work at Howard and how he's been able to broaden the impact and the number of people who are willing to be organ donors through education. That's something that can't happen within the walls of academia. And you know, Dr. Amaka's work doing this incredible expose on the use of race in EGFR calculation and how we as clinicians might need to evaluate our institution differently. So it really requires us to be creative and to think outside of the box when it comes to addressing these problems. And last thing I'll say just briefly, we need more diverse voices in the medical field. We need them from top to bottom, everyone from our clinical research coordinators and pre-med students all the way through to deans and academic leaders, hospital administrators as well. We need it across the spectrum because it's important that we have diverse voices from every corner of American life influencing the future of American healthcare. That's what will help to break down these silos and help to mitigate bias and disparity that we see.
Thank you for that, Ray. Very impassioned list of interventions. I just want to say Ray and I are both really active in initiatives around supporting Black men in medicine. As you can see, Ray is a part of a smaller cohort, the Black Men in Bow Ties in Medicine. It's a very strong contingency nonetheless. I want to turn to you, Lily, for a question. And you mentioned this a little bit about the language discrepancies and how that impacts access to care. Any thoughts about interventions that could be done at any level in order to improve outcomes on patients when it comes to the barriers that may occur when it comes to language barriers?
Yeah, thank you for that question. It's extremely important. We know that at least in Colorado, anywhere between 40 to 60% of the Latino patients have limited English proficiency. And in a recent one-arm feasibility study that we did using a community health worker that would basically help patients with social challenges, we found that oftentimes the community health worker was acting as a language interpreter when clinicians were meeting with the patients. And so in the next phase of some of the work that I'm doing, I'm actually having the community health worker serve in that role. Because what we have found is that many of these patients, when they're receiving dialysis, don't have language interpretation, so they can't make their needs known, and they can't ask questions when they're being told what their lab values are or what their diet needs to look like. And so a lot of the information gets lost. You know, imagine a registered dietitian meeting with a patient discussing, sort of the renal restricted diet, and not being able to do it in a way that's culture or language concordant. And so with the help of a community health worker, they could potentially, make that connection in a way that is individualized to that patient. And, another effort we're undertaking here in Colorado is connecting with the diabetic Latino community, also with community health workers, to sort of increase awareness of diabetic kidney disease and help patients make those connections to healthcare providers and understand that their medications are being, that they're prescribed those medications for to prevent progression of diabetic kidney disease. And again, all of this is because we know that so much is lost when connecting with patients that have limited English proficiency. Sort of going back to that sort of advocacy framework or steps that I provided, when you're thinking about how do we tackle language issues, think about the policy. So for example, at our hospital, all the teams round at the same time, and there are 4 language interpreter phones. And so all of them are being used at the same time. And so if you think through those sort of, established ways of doing things, you can make sure that at that time, in addition to those phones, there's like 3 in-person interpreters, or, so sort of think through, what are the issues with language interpretation? What are the communication barriers? And as everyone has recommended, it's engaging that specific community in that specific setting to better understand those barriers to fix or address the situation. Because every setting is different and every community has different language needs.
So in the interest of time, we're going to have to stop here. I did have a question for Dr. Simpson, but we're just, we're running up against the end of our allotted time slot. And I want to just say thank you to all of our panelists for joining us. Thank you to Dr. Cervantes, to Dr. Bignall, to Dr. Simpson and Dr. Iniana. Thank you for sharing your thoughts and insights. We do have a quick poll that we'd like to put up for you all to click through. Just for reference, I know there are some people asking about when will this session be available. We hope to have it closed captioned and available on our website within the week. So this will be available for you all to review and to share. We do have some upcoming events related to our equity and social justice series. As you heard very passionately from Dr. Cervantes and as well as Dr. Bignall, we talked about physician advocacy and the roles that we all can do as physicians to be supportive of our patients and go beyond the walls of the hospital and the ivory towers that we reside in. That conversation will be, I believe, on October 19th at 4 p.m. So please look forward to that announcement and please join us for that discussion with another batch of amazing physicians. We're going to talk about their advocacy work. I want to say thank you to Dr. Ying Wong. Thank you to Ying Wong and to Pinar and Fari in the background for helping us to move this along. And then always thank you to Dr. Reed for your support of our equity and social justice lecture series. Thank you again for everyone joining us, and we wish you the best start to your week, and have a good weekend.